Good afternoon, everyone. First of all, I'd like to thank my dear brother Aib Shirian for this excellent, valuable scientific content, and Dr. Ramdas for his valuable and effort. I am Dr. Sameh Hanosi from Egypt. For 3 successive days, we have enjoyed together multiple nice dissections, orations, concepts, and interventions. But my lecture will be somehow different. I will talk about clinoidal meningioma, microsurgical nuances, and strategies. And before I start my lecture, I'd like to ask you a question. Do you know how we solve medical problem in scientific way? In suggestion? And how we extract the evidence-based medicine from the available literature and practice? Okay. As we see here, this includes 5 steps, starting by question raised during your practice. This question should be formulated specifically by using BICO method. Then search about the answer in available literature. Refine the available data to find the best answer to your question. Then apply the answer to your practice. Then evaluate the efficacy and efficiency of your answer. And its circle starts again by modified question. This modified question will start by another question raised up during application. To start the circle again by modified question. And this is what we will do today. Evaluate available solutions in face of questions, to raise more questions to be answered in the future. And this will definitely reflect on our medical service, which we all are targeting. First, nothing to be disclosed, no conflict of interest. It's a pure scientific lecture for educational purposes. And our agenda today will include all these items. Why this topic? It's because clinoidal process is a very unique bony structure at border of anterior and middle fossa, which has multiple anatomical variations, pneumatizations, with direct relationship to vital delicate neurovascular structure, multiple variations of adhesions and invasions, a lot of ligamental attachment and real falls, with diverse growth pattern of meningiomas in this region. Visual field is the most common symptom and represents early with a small lesion if it invades early the optic canal. Still, there are multiple complications of surgery even in best surgical hands, and this is still reported as one of them. It's of high surgical morbidity and recurrence next to betoclival meningiomas. That's why it's important to put more focus on this topic. And as I said, it's of high surgical morbidity. This has been proven in this recent systematic review of 1,208 patients. Name of clinoid comes from Greek. Cline means bed. Oid means similar to, or from clinen, which is slope. And these categories of lesions have been described first by Cushion in 1938. The anterior clinoidal process is pyramidal in shape with 2 roots, originating from medial part of lesser ring of sphenoid bone. The other one is directed to optic canal and is named optic strut. 6 surfaces have been described in recent publications. Middle clinoidal process is an important anatomical variation which represents 36% of population. Multiple ligaments and dual faults are related to this bone, which should be oriented about to have more safe surgery. Multiple variations and degrees of calcifications, which may develop new foraminae like carotid cavernous foramen. Tip of this bone is an important structure too. It has described by Fukushima as shark tooth because it's sharp and able to injure the nerve structure easily. Neurovascular variations, its causes and perforators to be studied well preoperatively. The vascular supply of this lesion mainly from dual base arteries. That's why control of these feeders more early in your surgery is more better. These feeders appear in T2 as sunburst. Normatization of clinoidal process is to be put in mind during preoperative evaluation, and also different anatomical variations of optic strut. Clinoidal meningioma originate from the acnoid capsule of dual base with extension to all directions. Most common females, mostly benign, WHO type 1, adhesion to nearby neurovascular structure makes it gross total resection is difficult to be achieved. It's difficult to estimate the real incidence, but multiple density in size because of multiple diversity in size. But it's about 10 to 20% of all intracranial meningiomas. The most common presentation is visual disturbances. It represents about 50% of all symptoms. Other symptoms depend on size extension of these lesions. Preoperative radiology is a very important step in surgical planning, and full evaluation is recommended, which include CT, MRI, and cerebral angio. CT will give us information about the shape of process, its anatomical variation, bony nerve structures, hyperostosis, its pneumatization and calcification of ligaments around and inside the tumor itself. MRI is a cornerstone of radiology evaluation to study this tumor, its nearby neurovascular structures and invasion. Two sequences of MRI to be considered and helpful in your preoperative evaluation, which is CISS and VIBE. Both are sequences of T2 gradient echo, which give more information about CSF round and tumor extension. And to be noted here, using high resolution MRI is recommended to increase the sensitivity to detect the optic canal invasion. DSA may be helpful also in some selected cases. Loss of monocular visual acuity is the most common symptom, mostly due to chronic ischemia and mechanical compression. Many classifications have been implemented to help the surgical planning and to predict the outcome. These are the most famous ones. SAMI is the simplest one of them, classified it into two groups according to invasion of cavernous sinus. NANDA has added more items, including preoperative invasion, tumor volume, internal carotid relationship, cavernous sinus extension, and open canal invasion. Then classified it into two groups too. The most accepted and popular classification is the one done by Al-Mifti, 1990, which is concerned more about the location and the acnoid relationship to neurovascular structures. The most recent one, done in 2020 by Tao, and it's concerned more about direction of growth and expansion. Preoperative planning may include also preoperative embolization, but this recent systematic review didn't find it of great help, with increased risk of complication in 12% of patients. Endocrinal evaluation also to be considered, especially if there is medial extension. And when we get to the surgery itself, we will find two different perspectives, which are vascular and skull base. Vascular will start opening the sylvian fissure widely in the beginning and follow the vascular structure to the tongue. Skull base will prepare the bony corridor and widen the approach first. And each has pros and cons, but literature are in favor to deal with clinoidal meningioma from skull base perspective. What about approaches? Critch in المفتي meningioma book has recommended the wide frontotemporal approach and extension of it as needed according to lesion size and invasion. Supraorbital, transorbital, and transnasal endoscopic approaches are reported in literature. Recently, exoscope assisted is reported too. I will not go through steps of surgery in details, but the most common step is the bony work, clinoidectomy, which can be done either extradurally, intradurally, or hybrid. All have its indication, contraindication, pros and cons. And as I said, clinoidectomy is a cornerstone from skull-based perspective, and this is a trend for more than 20 years. Hybrid clinoidectomy has been described to have more an add-on value to avoid disadvantages of both techniques. As regarding external clinoidectomy, it's more preferable. You can start drilling after stripping the covered dura. You can use harsh diamond drill at the beginning to fasten it. For sure, not use sharp drills. Till you leave small eggshell to not injure the vital structures. Copious irrigation is a must to avoid damage of neurovascular structure by the thermal effect. It's not needed to remove the process after detach it from its origin. Take care more about the tip of shark tooth. Open the ligaments and the arachnoid by sharp dissections. Dealing with large multidirectional lesions through multiple triangles. Debulking it from side is useful to decrease the traction. Take care about perforators. It's recommended to open optic canal early to release the nerve, which alleviates the ischemia and decrease the rate of recurrence. Chiasmopexy may be beneficial if there is any postoperative residual, which in need for postoperative radiosurgery intervention. Repair the defect by not only fat, by also fascia to lessen CSF leakage. Multiple lesions and need multidisciplinary team evaluation and intervention, multiple stages surgery, and may be in need for radiosurgery too. And the favorable outcome increase with early surgical intervention, hyper-intense lesion on T2, invasion of optic canal. As regarding the complication, the avoidable ones will be less by more cadaveric training. Recently, it was reported that sheep head is a good model for training on clinoidectomy. In conclusion, clinoidal meningioma surgery is technically demanding surgery which needs well-known orientation about microsurgical anatomy and variation, very delicate study of preoperative images, neuroophthalmology study, and post-operative pre- and post-operative neuroophthalmological study. Careful drilling, training on cadaver is a must to improve your skills. These are books which helped me in preparation of this talk, plus 100 best selected updated papers, and I will stop here to answer any question. Thank you.
Thank you very much for this excellent talk. It's a very challenging subject.
Yes.
Do you also use regularly the Doppler, vascular Doppler?
Not always. Not always to use it if needed.
Okay,
Not
That's
all the time.
okay, that's fine. Any question
It's not.
in the audience? Comment?
Thank you, Dr. El-Morsi.
Just in time.
Thank you very much.
Now, I would like to invite our